Okay, my dear friends, I am Dr. Pramod Jog from Pune, and we are going to have a lively discussion related to the management of our outpatient during these period, and also what lessons we have learned and how we go forward. And we have with us Dr. Bala Subramaniam, our friend nicknamed as Bala with us from Chennai, and Dr. Rajesh Chokhani, a leading and a scholar pediatrician from Mumbai, and we are waiting for Dr. Gaurav Sethi from Delhi. And Bala, how are you doing these days? Because all of us for the last so many days are sitting at home. And how are you doing?
Actually, I'm not doing clinical practice. For the last 3 weeks, I'm not having private practice. That's number one. Two, but since I'm holding an administrative post in the hospital, I do go to the hospital every day, spend at least about 3 to 4 hours sorting out administrative issues without doing patient care related services. And in addition, I normally I do exercises and yoga for about 45 minutes a day. Now it used to be OD 5 days a week. Now it is BD twice a day, sometimes TDS also. 45 minutes in the morning, 45 minutes in the evening. I do my exercises, I do my walking, and I do my yoga.
Yeah.
Third thing is I'm not leaving my academics. The last 2 weeks I have been able to successfully complete 2 publications. I've got acceptance of 2 papers in the last 2 weeks, and I'm using the whip to my registrars, my junior consultants, my postgraduates to plan to get at least 3 more papers in the next 2 weeks. And of course, making these 2 papers required lot of cups of tea from 9 to 1 in the night every day for the last 2 weeks. With the end, I sleep around 8 o'clock in the morning. That's how it has been. And lots of phone calls, lots of my 2 sons are abroad. One is in Boston, another hotspot in US. The other fellow is in Brussels, another hotspot in Belgium. So every day me and my wife have a chat with them, find out because they are also sitting at home and working. And my daughter is in Bangalore; she's also working from home. That's how the 24 hours goes every day.
Yeah. Yeah, that's great. I saw one of your articles, online articles in Indian Pediatrics, and I congratulate you for that. And as you said, you are taking the exercise twice daily. For many doctors, now bathing also, taking a bath also has become daily. I know one of my friends who used to take bath once in a week. He has started taking twice in a day now. Anyway, now Rajesh, you are in Mumbai, and Mumbai is reporting lot many cases outside. But how are you maintaining your day, and how is the design of your day?
Two things. One, I have finished many new qualifications from WhatsApp University. And the second thing is, I am opposite to Bala. So next time our Honorable Prime Minister addresses us, instead of Sathiyon, he will say Hathiyon.
No, it's okay. But I am sure you must be maintaining your academic arm quite powerful because anyway, let us start with today's discussion. As far as I am concerned, I learned the French language online over last few weeks, and I am enjoying learning of the French. And I am also writing few articles on COVID-19. Anyway, now the discussion today is aimed at giving information to our colleagues as to with this particular onslaught of coronavirus on the entire world. The world will, we say is not going to be the same again. That is what many people say. And basically the bread and butter, our practice and the immunization and so many things have suffered. And the point is, now let us start with the discussion from a patient who wants to come to our OPD. We are not going to discuss anything about 31st December, the Wuhan and the Chinese market and the live animals and all. Everybody knows a lot many things about it. So we'll directly go to the practical aspect as to a patient from IT sector has called Dr. Rajesh in the morning at around 9. And he says, sir, I am staying about 20 kilometers from where you practice, but my son is running fever and I want to bring my son to your clinic. So what time are you going to come to the clinic? And I'm worried the police may not allow me to come to the clinic. So please guide me. So, how would you, speak to this gentleman who is calling you at 9 and wants to come to the clinic desperately?
Sure. So one of the important steps in this scenario, we will have to triage our patients. So when he asks for an appointment, I will have to uh, ask some more questions to decide whether I need to see this child physically or whether this child can be managed with some advice on the phone. Now, whether it's just an audio phone or whether it's a video consult or whether it's telemedicine, all that we can come to later, whatever modality anyone may prefer. But that's the first step. I would like to triage whether I really want to call him or no. Secondly, if I really think that he needs to be seen, then in my mind, I will have to kind of bifurcate my OPD hours into a section where I call the so-called well children, like immunization or general checkup or whatever, or follow-ups of some old diseases, versus acutely sick children. So I will have to make sections. I may do 2 hours this, 2 hours that, or on different days or whatever. That's individual. So these are the two main things that we will have to do to begin with.
Yeah, that's great. And Bala, if he wants some consultation, he says, "I'm ready to pay whatever you want. Give me some consultation on phone, or if you say I am ready to go for a telemedicine consult." What is your opinion? And are you indulging into all this telemedicine thing?
Two things, Pramod. One is that the telemedicine has been approved by the government legally. Recent
Right.
orders have been issued. That's one.
Yeah.
So, two is that telemedicine is going to be the future of pediatrics, I'm afraid. Three is that we don't have to worry about giving telemedicine consult in any form as long as we follow the guidelines issued by the government of India. The
Right.
guidelines are available in the net, and there are two requisites for it. One, you have to be a registered medical practitioner. Second, you are supposed to undergo training, and it is mentioned that the training is valid for 3 years. These are the two conditions that are available. Regarding my personal experience, I have not yet started telemedicine consult till now. Because basically, I'm a senior citizen who's always, very allergic to any new gadgets. I always require some youngster around me to help. These days, because of social distancing, I don't have PG sitting close to me. I don't have registrar sitting close to me to help me out if there is a problem with my phone or with my computer. So I have not started, but I'm afraid I'll have to start. Otherwise, I'll go foodless in the next 2 months. The way things are looking today, it looks like half of our pediatric practice is going to be through telemedicine in the near future. When I say near future, it may be a few months or it may be a few years, but that's a reality which one has to accept, and senior citizens like me has to get trained to do telemedicine. As far as what I do in such a situation, unlike Rajesh, I'm very comfortable in terms of telephonic or telemedicine consults because I'm working in a private children's hospital where we have initiated these services, I would say primitive telemedicine services. We have created an exclusive WhatsApp phone number in our hospital. This mobile phone is available with the registrar or as finally a postgraduate 24/7. And we are offering free telephonic services from the onset of the COVID pandemic for the last 2 weeks. This is what we have done. Our administration is going to set up a telemedicine clinic for our hospital with payment. But I believe using the several platforms that are available, Dr. Jagdish Shanapa, who is very well versed with computers and software, etc. He tells me, you tell me when you want, you buy a new phone with the WhatsApp, I'll get you trained in 1 hour. He's challenging me. I'm planning to do it sometime this week.
Okay, that's great. I'm told that the quality of the instruments used and the internet service, it does matter when you give the telemedicine consult. In addition, one has to have the consent from the patients that they are willing to up your advice, and at the same time one has to give an e-prescription, so with usual prescription with our name, then the date and the name of the patient, diagnosis with signature, everything. It's a routine thing. Only thing is consent is important. And of course, he should agree to pay you, because, you give the consultation. So some of our friends, they will say you now, you show the proof that you have paid either on Paytm or something, and then they release their prescription. So you have to be very careful. Rajesh, do you have any experience with telemedicine? Otherwise, you can just tell me as to how you speak to the parents on phone. What advice? He says, no, sir, there is another patient who says, I simply can't come, but tell me something on phone.
Sure. Before that, I hope you have noticed that Dr. Gaurav has joined us.
Is it? Okay,
Yes.
I am unable to see him on the screen.
Good evening.
Yeah.
Okay, you are not
even
seeing Gaurav's screen?
Yeah. Now I can see him. Yeah. Nice to meet you, Gaurav. Yeah.
Hi, good evening, sir. Yeah. Thank you, Dr. Rajesh.
So I think, of course, I agree that telemedicine is going to be a very important thing in the near future. But on the other side, I would like to point out that there will be a lot of limitations. So one is, while the technology bit is different, as Dr. Pramod said, some of us have been handling phone calls since donkey's years. And therefore, that's a kind of telemedicine which is free. Now, suddenly we want to do the same telemedicine, but wanting to charge for it, that transition will take a little time. Secondly, I don't think telemedicine will be a replacement for our physical clinics. It will be a very important adjunct for triaging and minimizing the number of people that are there in the clinics. So because telemedicine, typically they say that you don't see a unknown patient on telemedicine. And we pediatrics, we are used to short illnesses most of the times. So therefore, what we will be using telemedicine for, as I guess, is known patients with a short, fresh illness, where I am triaging whether it's a minor illness on the telemedicine platform, or I want to see him. That's one. And follow-ups become little easy with telemedicine so that they don't crowd our clinics. Of course, we can't see newborns, we can't see very sick children. We won't be able to restrict to telemedicine once the fever is beyond 3-4 days of illness, etc., etc. So those are the other limitations. Gaurav, you would like to add anything?
Yes, sir. I think, as you said, we've been handling phone calls for free for a long time, and this transition is going to take some time, but I think people are very receptive to the new technologies these days. And by giving video, I've started giving video consultation for past 2-3 days only. But the benefit is that I'm using a software for past 3.5 years, which now has incorporated the video consultation into the same platform. So I'm seeing the patient's records on my iPad, as well as typing a prescription while talking to the patient, while seeing the patient. And I think the limited experience that I have had has been very gratifying, because you see a kid who's playing comfortable in his or her own home environment, not petrified of getting a shot, because when they come to us, they have this back of mind fear that maybe I'm going to get a vaccine and my parents are just lying that no vaccine today. So he's that comfortable zone mein hai bacha. And then when you many things that I've seen till now are actually manageable, like a 6-month-old child with hard stool, which has petrified the parents. So first time parents, they saw a speck of blood in it, and I could counsel them very easily. And by taking an appointment for a video consultation, the benefit over a routine telephonic consultation is that they're getting 10 to 15 minutes of my dedicated time. So it's not just that I've just picked up the phone, ye de do, and finish off in 30 seconds. This way, they're getting 10 to 15 minutes of my total attention. I'm giving them dietary advice, I'm giving them other supportive care, and I'm giving them a prescription which has all of this written as well. Obviously, we're not going to write medicines for everything, but there are limitations. But there are, like a child with dysuria, like the parent called me up yesterday, so I could counsel them on the phone what all measures are to be done and what tests to be done. So it was a very, I think it was a gratifying experience for me as well as for the parent. And they can obviously get back to me with the report next day. And it's a very, very good way of triaging. So I think that's going to help us, hopefully.
Yeah, yeah, and
And I would request Dr. Bala sir as well to be more receptive to this. As your kids are in US, you must be having video chats with them. It's as easy as doing a video chat with a patient, writing down a prescription, taking a snap, and just sending it across, and that's about it.
yeah. And Gaurav, in case if
Sir.
you want to have a look at the throat of the child, in case the commonest complaint is fever, cough these days. So what do you do when you give a telemedicine consult?
So that's a tough one. So, but still, it's safer through the video consult these days, because now we are told that do not look into the throat of any child considering the risk of COVID. But with the phone, if the parent can kind of make, and in fact, I would like to share an experience of couple of months back. This kid, he's 3 years, I guess, about 3 years. He's petrified of me because he's been vaccinated from birth at my clinic, and he becomes very, very rigid when I try to examine that child. And he was having fever, throat pain, but would not open his mouth. With all types of bribery, with all types of cajoling, he did not agree. Then we tried to forcibly see the child's throat with the spatula, and we failed with 3 people holding him and trying my best. I could not see it. So finally, the father went back home and made the child open the mouth and took nice snaps with flash, and I could make out that the tonsils are clear and it's just a viral kind of dysphagia or odynophagia or something. So
I'm told
maybe
that the
this,
back camera of the mobile gives a good
yes,
picture of the throat.
sure, yes.
Okay, that's great. So the patient, the one from the IT sector, in Pune there is a lot of IT sector. It's information technology group, but I say IT stands for inquisitive and troublesome. So they have hundreds of questions, and they now some or the other the patient is not satisfied. He says, Dr. Jog, I am coming, and he starts from his house. Only thing I tell him that as far as possible, you use your own vehicle and come, because if he comes in a cab or an auto, I tell him, in case if someone who is positive, he has already used this particular cab, then you will be in trouble. So you better come only if you have your own vehicle. I have also become little more liberal in asking some of our clients to consult the pediatricians in their own locality, okay, and or maybe a family physician, because he need not travel all the way 20 kilometers or 10 kilometers and come to my clinic. Anyway, now the patient has landed near the clinic, and there are a few more who are outside the clinic, and they are waiting for Dr. Jog to arrive. Now, Dr. Bala, what would you instruct the people at the reception as to how to handle these people? They want to just rush in inside. Our people, they have their child with father, mother, aunt, and 5-6 other people, and eager to get inside and get the first appointment with you. So how would you instruct the reception, and what all they should do, and what all they should tell these parents who have already come outside the clinic?
One thing that has happened following the onset of the COVID-19 pandemic is that more Indians have started having faith in the queue system. That has not been there in our blood at all for quite some time. And I am sure this habit is not going to die down hereafter. So nowadays, if you ask them to follow the queue system, it's not going to be difficult like in the past. That's number one. Number two, because in my clinic, I close down by 8 p.m. and I don't see beyond a limited number of patients. They sometimes pounce on my secretary saying, I know the doctor for 15 years, why are you not allowing me? And such things happen. I'm sure such things won't happen in the future. He'll be happy if he doesn't get seen by me in a crowded clinic. on the other hand, two is that I would definitely what you call practice social distancing in the clinic by giving staggered appointments. Say, for example, if there are going to be 20 patients I'm going to see over a period of 3 hours, I'm going to ask them to strictly follow the time schedule, follow the social distancing schedule of whatever distance that needs to be followed. 1 meter may change to 2 meters in future, because they're saying 1 meter is not enough, 2 meters are not enough. Now they're talking about 3 meters. So it may vary in future. Nobody knows what's going to happen. So we'll follow whatever that is now being advised. We'll ask them to wait, and I'm going to plan to instruct my secretary to take all precautions, at least with the 3-layered surgical mask, and then find out by triaging what is the problem. And then if it is going to be a respiratory problem, I'm afraid, considering my age, at least for the next month or so until the whole situation improves, I might not see such patients. I may guide them appropriately, either through a WhatsApp phone or connect them to my hospital phone and give them instructions. And if it is going to be something like elective, for example, if they are going to come for immunization, 4 babies are going to come, I will finish them first and then keep the other cases which may be potentially COVID-19 infected later staggered, so that the risk of transmission from one patient to another does not occur. I will try to minimize personal consultations as much as possible. Fortunately, in my clinic, there is another adjoining room with a glass window where I can see the child. I can do telemedicine even in my clinic, provided they are not sick or obviously infective. I can start doing it, and I will try to minimize consultations. In fact, my professor used to say, in pediatric practice, even if a chimpanzee sits in the same clinic 6 to 9 in the evening, it will do well over 10 years, provided it doesn't bite the customers. Most of our illnesses are self-limiting. If I see 30 babies, at least 15 of them, only the parents would require counseling, and the child might not require medication. I don't see all tertiary care cases. I see primary, secondary, tertiary care cases. Only 1 in 10 will be a problem case. I'll have to spend 20 minutes seeing the file and still go without a diagnosis or treatment. So in such a scenario, I can actually selectively divide these cases and see, this is the plan I have. But I'm afraid this may not be possible for everybody. In fact, it is suggested that a senior citizen like me can have a junior to take care of those high-risk cases, see the low-risk cases, and get away with it. These are all the thoughts which come to my mind. It may not be possible for somebody who's used to seeing 200 cases per day. I don't know how they are going to manage.
Yeah, no, actually, quite a few pediatricians who had a practice of 200 per day has come down to 20, and even to some extent up to 2 also. And many of my friends have started getting withdrawal symptoms. I had heard of withdrawal symptoms only for some other reasons, but now they are getting withdrawal from, number of patients who are less. Anyway, Rajesh, how are you handling these chaps who are waiting outside your clinic?
So Pramod sir, in a lighter vein, the patients have now realized that they can do without us for the last 1 month. So if that thing persists, then those days are gone when there will be a crowd outside the door. Okay. Now coming to the actual, so like Bala sir, some of us do practice by giving appointments, etc. But there is a good half of us who do not practice by appointment, which means either they have a token system where someone comes and writes his name or takes a token and then comes back, or they just walk in. So those people are going to have a problem whenever post-lockdown we start, but they will have to then gradually move on to some method to try and minimize this. So they may start using those apps which they give tokens, and then the app tells you that you are now next in queue, so you come back and things like that. The other issue is, we'll have to be practical. This is all ideal, social distancing. But in a city like Mumbai, half the clinics are in a total 150 square feet area. So where is the patient going to distance? So those who have been seeing large numbers are going to find it difficult to move to a safe system for both doctor and patient alike.
Yeah, I think giving an appointment is the good suggestion. In addition, what I do is, even if they are waiting outside the clinic, I see that the first one who is inside, when he goes out, then all other sterile precautions taken inside, then only I get the next one inside. So at a time, I allow only one. Gaurav, you wanted to say something?
Yeah, sir. I think more and more we need to use softwares in our practice so that the queue system, there's a live queue in the software. The patients get updates that your appointment is at this time, and we need to kind of graduate to a kind of practice where walk-ins are discouraged so that there's segregation. And we need to put up proper displays outside the clinic which tell them that only one attendant allowed, do not come without appointment, as well as we have to put up displays which say that do not enter without wearing a mask. Many other things which I think we'll cover regarding the safety measures which the clinic should be using. But I think the role of software is must, and we need to become a little more labor intensive. What I mean by that is that there used to be a joke that to start a pediatric practice, you just need a stethoscope and a table chair. Those days are gone now. We need more staff who need to attend to the calls so that people come with the queue system. We need a staff to manage the crowd. And for Delhi, Mumbai, and other places as well, where people are coming in their own cars, they are made to wait in the car. If they've come without an appointment or there's longer waiting than expected, then they're told to sit in the car, and we'll call them in. And I don't know about your city, sir, but in Delhi, it's very common in the evenings, people sit in their cars with the AC on and enjoy a small drink. So they're used to sitting in cars for a long time. So I think that's one of the ways we can ensure
the
segregation.
health educational material which was in the waiting rooms, now I think it has to be shifted outside the waiting room, because then people can have a look at it. And there are people who have appointed the security guard. He has a sanitizer in the hand, and he is himself triaging by that thermometer, and then segregating at the entrance itself. But as you said rightly, he has to enter with a mask, and one patient, only one relative. So that is what we have been following. And as far as possible, no file to be brought. Otherwise, they bring bunch of papers. So please come without any file. You send the earlier prescription on a WhatsApp. I will have a look at it. In fact, you said
Again,
about the chairs.
Software would be helpful there without files if we want to check the page.
And in fact, I have removed all the chairs from my waiting room so that nobody sits there. As it is, people from Pune are known for all that. But then I have removed all the chairs, and people have to only stand now, because they need not infect the premises anyway. So now the patients are waiting outside, and the attendant has called the first patient inside, and with a mask and only one relative, he has come over here. We have segregated him. He has been segregated as the one for immunization and one for the fever, cough, cold, the symptomatic patient. Okay, now he has come to the reception counter, and the receptionist is now dealing with him. He says, give a paper. So there is no paper now, and now he wants to enter into the cabin. And as all our doctors, they come after the patients. Dr. Jog has come after half an hour, and he has entered, and then he has, of course, taken all the precautions while entering, and he is going into the chamber. Now, Dr. Bala, just tell us as to how you should appear in the OPD in the current scenario, and how you should welcome the patient, and how should you handle in your own style in the cabin. Now you have entered the cabin, and now you are going to handle the patient after some time.
Now, I know one of my pediatrician friends in Coimbatore who doesn't have a chair for himself in his clinic. He doesn't sit in a chair. He squats and examines patients if needed. Otherwise, there's no furniture between the patient and the doctor. That is an idea which I'm thinking of. I'm planning to remove my chair, and perhaps the table, or perhaps get a small table. These are all thoughts I should do, all serious thinking about it. Remove my chair and follow the social distancing norms of seeing a patient from a 2 meter distance. And of course, the ornament which I have been using for so many decades without much use, the stethoscope, I think I'm going to give rest to the stethoscope. Most of it is going to be only a questioning and, if necessary, palpation, percussion, occasionally for some forgotten things, etc. And of course, hand rub, I'm definitely going to use in plenty. I don't intend having a wash after every patient. I plan to use only hand rub between patients. And gloves, they say if you want to use, you have to change between patients. It's not possible. Best is a hand rub. The next problem that is going to come to me is if I put the child on the couch, what do I do for sterilizing for disinfecting the couch? There are novel methods. Once upon a time, we tried in our hospital. One of the newspaper companies gave us enough newspaper waste, and we use them after every patient. Something like that I have to think of. And then also provide hand rub to the mother and the child if I were to examine the child, and also adequate hand rub. I don't know how much alcohol is going to be absorbed into my system after seeing quite a lot of patients and using the hand rub repeatedly.
Bala sir, don't keep very high hopes.
70% alcohol constantly on my fingers. I don't know what's going to happen, but so far nothing has happened. And these are the thoughts which have come to my mind. But then all this is going to be difficult. Sometimes I wonder, in fact, I even would say pediatric practice is going to be BC and after AC. BC is before Corona, AC is after Corona. Our approach to patients, our handling of patients, our talking to patients, our handling of our hands, our equipments, everything is going to change, starting from the use of a pen to mobile phone to door handles. I don't know if it is really possible for any of us to humanly practice this 100%, but I can tell you honestly, the fear is there. Definitely, we have to follow until 60%, maybe 50% of our population is infected, and all of, including us, and we get out of it, and we have antibodies before another virus comes into the community.
I can understand. And Rajesh, yeah, I'm coming to you. You are in Mumbai, and it's quite humid and sultry, and the days are very hot. So, will you put on the AC in your cabin? Because we are worried. So, what is your opinion?
Yeah, so I mean that's what. So the recommendation. So what I wanted to say is, see, there are some ideal recommendations, which the aim is to try and minimize the risk next to zero of us getting infected. But then there is a gap between what is ideal and what is practicable. So same thing is about the AC. So if my clinic is well ventilated and my temperature in my city, in my area is such that we can tolerate with the fan, then that will be one option. But there are clinics in Mumbai where if you open the window, you are looking into your neighbor's kitchen or bedroom. How can you then keep your window open and there's hardly any ventilation there? So these are all practical issues. Similarly, like what Bala said, we'll have to, I think, so if we look at two big things which have a big impact in reducing risk of infection from patient to us or vice versa, is wearing of mask, simple surgical mask by patient and doctor, and hand washing. I mean, if we follow these two things, which are probably followable, I think it will drastically reduce. Of course, it can't reduce to 100. I mean, it can't eliminate the risk 100%, but that's the main thing.
Yeah, and Gaurav, now that, as I told you, those IT sector patients, they are going to come close to you and see whether Dr. Jog has really, has this N95 mask, and whether he has really a good sanitizer or a sanitizer from a duplicate market, and so many things. He has hundreds of queries in his mind. So what are the ideal ways of protecting a doctor who is sitting in the clinic, including the mask, the hand sanitization? We speak about these certain things these days as the PPE, the personal protective equipment. And our IAP members, these are the income wise average pediatricians. So those income wise average pediatricians will always ask you whether N95 can be reused, or whether I can keep 4 masks and the first one I will use after 4 days. So are there any thoughts in your mind, some which would come close to ideal situation?
Yes, sir. So just like Dr. Bala said, that AC and BC, so there are certain things which I picked up over the years. Like after H1N1, I started wearing mask while checking throat and when patients had a lot of coughs. So that habit has stuck with me for past so many years. So I think from now on, it's going to be, the mask is always going to stay on in the future. Then again, hand sanitization also I started when H1N1 was there. So it was already a practice, but now it's a manic obsession, I think, with all of us. Plus demonetization taught us that digital payments is the way to go. So now even more so with Corona, we are trying to like we put up outside also to that avoid cash and pay digitally. Regarding that, putting the patient on the couch and checking the weight on infant scale as well, we are trying to avoid that, but there are disposable sheets which are available in rolls. So I've been using for young kids below 6 months just to it's a good practice, as well as just to pamper the parents as well, to show that, okay, we are being very clean and hygienic. So we put disposable sheets when we need to put the patient on the couch or on the weighing scale. Regarding the PPE, sir, I think that's the major discussion point for the past so many days, that what is enough to protect us? Because we all know that children don't get that severe disease. They get by with mild symptoms, and it's more that the practitioner and the staff and the practitioner's family, which people are most worried about, that we'll get the infection, we'll transmit it to our parents who are in the really vulnerable age group. So as per the recommendations, it was that a simple surgical mask and gloves is what was recommended by the authorities. But again, the gloves has that issue of not being able to do proper hand hygiene with gloves on, and it's not practical to change gloves in between patients. So again, that hand rub becomes very, very important, that we do it properly for 20 seconds. It's not just putting sanitizer there and just, that's it. It's a 20-second hand rub. And my concern was that in pediatric OPD, where kids don't shy of coughing or sneezing on your face, is a surgical mask enough? So now from Saturday onward, like 2 days back, I have shifted to an N95 mask after so many inputs from so many places. And there are now CDC recommendations also, where they say that, okay, for OPD, pediatric OPD, you can consider N95, but again, the availability and the cost. So as I said, labor intensive ho gaya practice, and now cost intensive also, because now we are spending about 500 rupees per day on PPE, because mask for me, mask for my staff, at least surgical mask, which is, the cost has shot up 5 times, and a cap, and I'm wearing a washable OT gown like we used to have earlier. But the N95 mask can be rotated, thankfully. Even there are guidelines from All India Institute as well as from CDC, which say that you use a mask for 1 day and you put it in a brown paper bag, you hang it somewhere, or you keep it in a place where it doesn't get soiled, and you mark it that this is when I used it, and you can reuse it after 4 days. So you have 4 masks and you use them. You can use them up to 5 times as per All India Institute. So that 20 days would be what 4 masks would last you. So day 1 would go to day 5, and then to day 9, 10, whatever. So in 20 days, you can get by with 4 masks. But CDC even goes on to say that you can continue reusing the mask till it gets soiled, or there are visible kind of damages, or it starts leaking. You can feel the air leaking from the sides. But they suggest that you should try to protect your N95 mask, either by using a face shield or by putting a normal homemade mask over it, so that a direct cough or sneeze doesn't land on it. So that way you can prolong the life of your N95. It's become a very precious commodity, I guess. So hand rub, a good mask, an OT cap, and at least a doctor's coat is what we want to do. Plus, it's recommended that we wear OT scrubs when we reach the clinic, but if that's not available and not practical for you, so I have kept 2 denims and 2 t-shirts in the clinic, which I go and I change into them. And at the end of the OPD, I leave them there. It's washed in the clinic, and next day I get the second set, and the third day I get the first set back. So I don't come back. I don't bring those clothes back home. So that's how my version of OT scrubs.
Oh, so we never dreamt of changing clothes in the clinic, isn't it? But the time has come that now we have to change the clothes in the clinic. Anyway, yeah, Bala will come to you.
Yeah. I think in the history of pediatrics, there has never been something like this where pediatricians are worried about themselves more than about an infectious disease killing a child. This is history. This never happened. I don't remember any infectious disease in pediatrics which has frightened the pediatricians themselves rather than the children or the caregivers. This is history, and this is unprecedented. That is one. Two is that in our own hospital, what we have shortage of PPE, we have started a separate isolation ward for suspect COVIDs. We have major problems in PPE availability, but we have sorted out the problem by sterilizing and reusing, and the ETO sterilization has been validated by our microbiology department, and we are reusing it. This is something which we have to do in India with the pandemic becoming more and more aggressive.
Okay, yeah, I can understand. And hand washing also is an important step. And I just would like to inform our listeners, people usually forget the 6 steps of hand washing. And there is a mnemonic called Samman, SUMMAN. S stands for Sulta. Sulta is the front side. U stands for Ulta, that is the back side. Okay, then the M stands for Mutti, that is the fist. Okay, then other M stands for the wrist, Mangat. Okay, then it stands for A, that is Angutha, that is the thumb. Okay, and the last N stands for the nails. So remember SUMMAN, at least for those who know some of these words. And so you should follow all these 6 steps and keep the Samman of the patient in front of you. Of course, hand washing is something important. In addition, people say that you also refrain from certain things which are related to the hand, like avoiding the handshake, touching the hand to the face, keeping hands distance. In case you are coughing in a handkerchief, see that it is thrown in the dustbin, and also coughing, in the elbow. And the term that I found out was it is called as Dracula cough. Dracula cough is, coughing in the elbow. Anyway, all these things now people know about it. And now Dr. Jog is being confronted by this IT fellow, and he has brought his son, and he says, sir, the child has fever for the last 2 days. The child also has cough. And now, Rajesh, how will you proceed? So what all questions will you ask? He is sitting at a distance of 3 feet from you, and he wants diagnosis, and he also wants treatment. So how would you approach this person?
Yeah, so I think as we have learned traditionally, we will ask first of all about the details of the fever, how high is it, responsive to antipyretic, whether the child is playful, interfebrile, what is the trend of fever, what are the accompanying symptoms. So if he does have a multi-localized illness, like he has a cold, cough, some other symptoms, etc., then I know this is a viral illness for sure. So my first distinction is to rule out seriousness. So all our typical characteristics of fever which tell us which child is serious, we will rule that out. Now, once I know it's not a serious illness, then my next question is which viral? Now, is it an ordinary viral or is it COVID? Now, as of today, no one of us, not even Rajnikant, can see and decide whether this is COVID or not COVID, right? So we need a test to decide whether it's COVID or not COVID. And as of today, we are not, our strategy is not to ask for a test in a child who's apparently not a serious or a severe acute respiratory infection. And he also doesn't fit all the other criteria like foreign travel, contact with a known patient, uh, immediate contact of a family member, etc., etc. So if he doesn't fit into all those criteria and he's just a mild illness, then we don't say it in so many words that this could be a mild COVID, but we tell them that it's a small illness, it will get better with symptomatic treatment. But we do enforce upon them the need to kind of home quarantine that child and minimize contact with other people. Because as we just discussed, it could well be COVID, a mild COVID, and he could spread it to others. So that bit we will have to explain to them.
Yeah, that's a very important point. So our listeners must carry home this message that a child many times is a asymptomatic carrier or an amplifier, and it is important that even if he has mild symptoms, he is rather kept at home. That is what is called as quarantine. That is home quarantine, even for the mild symptoms. Now, Rajesh, 2 days, what all.
Gaurav wanted to add something. Sorry, Gaurav wanted to add something.
Yeah, Gaurav, you want to add something?
So just wanted to say that for a short illness, I think in no other illness is the family history more important than now, because if the family history is suggestive of somebody having a severe viral illness, then definitely we're going to advise them a test. And you were right that family focus of viral we always ask for, but this for this corona BC practice. AC practice, sorry, after corona practice, I think the family history of a viral focus of a severe viral ILI type of presentation is extremely important to decide whether a test is required or not.
I agree. In fact, I think a few days down the line, when the tests are little more freely available, asking for a corona test will become a little more liberal, and we would probably be able to order it in a close by lab. That scenario may come in the next few days.
Yeah, it will come. And
freely
then Rajesh,
available, but not free. If it stays free, then it will not be freely available.
yeah. But then Rajesh, the parents want something in the prescription. They say, sir, kuch to di dijiye, because the child has been unwell for 2 days. So what will you prescribe them on paper?
I think we prescribe just an antipyretic SOS as we have been doing all these days for such a non-severe viral illness. And for other symptoms, meaning for say cough and cold, usually we don't prescribe any cough cold medicines. So if they insist that the child is, so again here, if he's coughing badly, then one more criteria is added for it becoming potentially COVID. So then, my approach to him changes. So largely for a child who is mild illness, I would probably restrict to paracetamol, plenty of fluids, normal diet, etc., and wait and watch.
Yeah, that's fine. But some of our colleagues have a habit of giving this ibu-para combinations. What is your opinion about that?
No, so now with those stray reports saying that ibuprofen could have added to the mortality of some patients in Italy, etc., we should avoid. Now, anyway, a lot of us have been sticking to paracetamol all these years. Now, in this current scenario, whether that ibuprofen is proved or not, if we prescribe it is Murphy's law, that patient only will come and catch our throat. तुमने ibuprofen लिखा इसलिए ऐसा हो.
Yeah,
So
you're right.
I think it's best avoided.
Yeah, you're right. And in the in the same continuation of the same story, the fellow says, okay, very good, this appears to be mild viral, I am going home. Now just tell me, when do I return back, or when do I call you back? So I will tell him.
So that's where telemedicine in any form will come in. So once I have seen this child, I would like to get the follow-up on phone, video, WhatsApp, telemedicine, whatever. And that would keep me in touch, and I can pick up the child when the child is worsening and needs further action.
Yeah. So in any case, what I do is, on the prescription, I have started writing at the bottom, explained about the condition, danger signs explained, and nasopharyngeal swab SOS. That is what I write to be safe in practice. And I always ask him to contact my fellow colleague or a pediatrician in his vicinity I tell him, okay, now that you have come all the way here, but now after 2 days, you better show either the family physician or the pediatrician. There is no way, there is no reason for you to come, because the purpose is to confine the people at the areas where they are. So you be there and let me know. And in case if he wants to know, or if you want to tell him about the danger signs, then what are the danger signs? Gaurav, will you like to tell certain danger signs which we should inform him?
So I
Maybe
think
one or two.
the most prominent would be drowsiness, lack of energy, a severe headache, body ache, the child not being well and active when afebrile. I think the same things which we've been following in the past. Plus, again, if somebody in the family also gets a very bad influenza-like illness, that would again be a sign that we need to kind of follow up this child and get an investigation done.
Yeah, and of course.
And in today's scenario, a bad cough, and if he starts breathing fast, if they can make that out, so we'll
Difficulty
have to
breathing,
tell them.
drowsiness.
Yeah. And Bala, do you have anything to add to this clinical discussion?
Basically, I admit to my patients that we cannot differentiate COVID-19 on clinical grounds. I admit my inability to do so. Number two, I counsel on warning signs. The common triad, I tell them, if the child is unable to sleep, unable to feed, unable to breathe comfortably, or is drowsy, passing less urine, intake is poor, you have to reach the nearest health facility, and I give them emergency number of my hospital or ask them to go there. That is one. Two, Rajesh talked about ibuprofen. In India, there is more use of ibuprofen with paracetamol or mefenamic acid with paracetamol. I think that should be discouraged. People may think that paracetamol is there, I can combine and give. That should not be done. It should not be used at all. Only paracetamol at the appropriate doses. That is two. Three is, what is going to happen in the near future, like dengue, people asking for tests on day one. That is what is going to happen. Once the regulations are relaxed, where OP testing for COVID-19 is going to be open, that too, if it's going to be free, there should be some way we should regulate this. In fact, they cannot go to the lab and get it tested positive, and for day one, well child, asymptomatic child, it will cause unnecessary panic. Third thing is, there are a few situations in which even on day one, in a reasonably well child, I will be worried. One, child who is immunocompromised. Two, child who has a chronic disease like renal failure, bronchiectasis, malnutrition, celiac disease, cystic fibrosis, just a few examples. Three, when I know the family history, that there is somebody in the family, elderly, who's high risk for COVID-19. Four, contact history, travel history. In these four situations, I might be more aggressive in testing for COVID-19 once the regulations for OP testing are relaxed. At the moment, unless a patient is hospitalized for SARI, severe acute respiratory infection, COVID testing as outpatient is not recommended routinely. Of course, the government authorities may do it for contact tracing and for public health purposes and for quarantine purposes. The other thing is, now we are also worried about not doing the test if it turns out to be positive. But that we can always defend, because one test negativity does not rule out it may become positive later. These are the thoughts at this point of time.
Yeah, wonderful. And now, yeah, Rajesh, you have some point to add? Yeah. You're not audible. Rajesh, you are not audible.
Hello? Hello? Hello?
Anyway, we will come to you, Rajesh. I will just request the technical staff to look into the audio of Dr. Rajesh Chokhani. Maybe till then, anyway, now, Gaurav, the patient has come out of the chamber. I have told him not to touch anywhere. Only now, most important thing is that he has to pay, because he has taken all the consultation, so much of time, and now he is at the counter again. What are the precautions to be taken at the time of payment at the counter, in brief?
I think we need to encourage more of digital payments, and that was the message from the demonetization shock that everybody got as well. So Paytm is very convenient and very well accepted by most people. UPI payments, we put up the scan code at the reception where people can just scan it and pay. And otherwise, there's a card payment, and there are now wave and pay cards where they don't even need to hand over the card to the receptionist. They can just wave it against the machine or swipe it themselves, put in the pin themselves. So I think digital payment is the way to go, and that's been happening gradually since demonetization happened. Many people for vaccination especially, they've been using. Mothers come in with the husband's card and they're very happy swiping it.
I know that's true. But then, Gaurav, even if we use these cards, there are some people who will always
Yes,
pay
sir.
by cash,
Yeah.
and
Yes.
for them,
So
some
we are
of
trying to disinfect the currency notes. So I couldn't find some very genuine source of how to disinfect currency notes, but there are sprays available with isopropyl alcohol plus benzene compound where you spray it on the note. It'll be wet for some time, but it dries up. But what we are doing right now is we're taking a spirit swab and swabbing down the currency note and letting it dry for some time, and then we are keeping them in transparent pouches. So we are not kind of immediately
no,
using those notes.
no, don't worry. I will give you a very good solution. In
Yeah.
my clinic, I have a cardboard box. I ask people to put in the currency notes into the box, just that they put it in the temple. Only I ask the receptionist to ensure that he is putting only notes and not the flowers and the leaves of the tree inside. And then at the end of the clinic, you see, this virus is very susceptible either to heat or to alcohol. But putting alcohol on the currency notes is unheard of. So that's why I have given them one iron, the iron which we use for ironing our clothes. And I put the currency notes between two layers of cloth and put the iron onto that. And the coronavirus usually gets killed in case if it is there. You can try this, and the patent of this particular idea, lies with Dr. Jog here. Anyway, at the end of the session, do not forget to take the cash with you. And then now the patient has left, the other patient has come inside, and now Dr. Jog is sitting and ready to leave the clinic. And Dr. Bala, at the time of leaving the clinic, what all Dr. Jog should look into? Of course, all of you can give your inputs. Now the clinic is about to be closed, and now we are going to leave the clinic. So Bala, any tips at the time of leaving?
At the time of leaving the clinic, we are supposed to clean the premises completely, starting from the computers that we use, to the cell phones we use, to the landlines, telephones, to the couch, to the chairs, to the stools, and also your machine which collects cash through cards, and also the floors, toilets you have with sodium hypochlorite and or Lysol in the concentrations prescribed. The best part is this is supposed to be done by a healthcare worker who has also got to be protected with gloves and the thick gloves and N95 mask, etc. Unfortunately, I have not opened my clinic. I have not started practicing it. I would have to start doing it. But in the hospital, the healthcare workers have been given instructions to do all this. Most importantly, last but not the least, they should also be trained to do proper waste management in institutions as well as small clinics, used materials, syringes, swabs, gauze, cotton, etc., which we are not going to use aggressively these days due to COVID-19.
Yeah. Acha, now, Rajesh, there is a small little question. We discussed about fever and cough but there are likely to be some other symptoms which people say could be COVID, like 10% patients having the GI symptoms and all. So these are the most common symptoms. One is fever, cough, other is of course loose motions. So just in a brief, just tell us as to how to handle this chap who has loose motions for the last 2 days. Again, your audio is giving a little problem. I request the technical team to look after the audio of Dr. Rajesh Chokhani. Rajesh, are you sure that you have unmuted yourself?
Not audible. Not audible.
At the left hand corner, yeah.
No.
No. Anyway, we will request the technical team again. Till then, we will continue. Bala, just quickly as to how to handle this child with.
Yeah, we must remember the clinical manifestations of COVID may include some non-respiratory symptoms. Whatever little data that is available in literature suggests that children might have diarrhea, might have some CNS manifestations, might even have a rash. But yesterday I saw in the AAP website, they have already described a child with Kawasaki in whom they have proved COVID-19. So Kawasaki is known to be associated with infection. So all this can, whether this COVID is responsible for the disease or not, we don't know. But it is believed that varied manifestations could occur. That is one. The second interesting thing described in literature is that COVID may be a bystander in a child who has got influenza, who's got adenovirus infection, who's got RSV infection. And just because COVID-19 is positive in a child, the child has got lobar pneumonia. The lobar pneumonia may be due to pneumococcus or adenovirus or mycoplasma rather than due to COVID-19. Similarly, if diarrhea is going to occur, it may not be because of COVID-19, it may be because of concurrent E. coli or shigellosis. Similarly, various other manifestations are being described. Only in future we will know whether they are associations or true manifestations of COVID-19 infection. The story is yet to evolve.
Okay. Gaurav, I have two important questions for you. One is that, the fellow from the IT sector, he left the clinic, and after 2 days, somehow, or maybe after 3 days, he calls you saying, sir, the child has had worsening of symptoms and he has developed tachypnea, and we had been to the hospital, COVID designated hospital, and they say he is COVID positive. And either you could not diagnose COVID-19 when he came to your clinic, or my child got it from the clinic where we had come. Okay, so now you are in a fix. You have taken all the proper precautions, everything, but now the father is accusing you. So how would you approach such a situation? Because the days are not far when we may face this situation.
So I think just like Dr. Bala sir said, that we need to be honest with the patient that it is not possible to distinguish COVID-19 from other illnesses in the initial phase, even when it's actually not just initial, but it is difficult clinically. So we need to be upfront about it, that it's not possible to suspect just clinically. Right now, the child seems well enough. If there is any deterioration, as you said, you put a footer that if there is any deterioration, the test will be required. So you put it out there that, okay, testing may be required for anybody and everybody who is not responding the way he should in any illness, since there can be non-specific symptoms as well. The second issue again goes back to how good your precautions have been. So if you have been following all that we've just been talking about segregation of patients, physical distancing of patients, proper hand rub, when the patient enters, you're making them use hand rub, everything you've been following, then I think you should not be liable to any such accusations. Although you cannot make everybody shut their mouth, and people are going to, kuch to log kahenge, logon ka kaam hai kehna. But if we have done our due diligence, then there should be no reason to fear any such eventuality.
Yeah, no, I am more afraid because, later on the police will call me and ask me to shut down my clinic. So what to do now? What is the answer?
Again, sir, this is a very pertinent worry in all of our minds, that if a patient we've seen, the patient may not accuse us, but if a patient we've seen who came in with fever, cough, and later on turned out COVID positive, would me and my staff and my clinic be quarantined? So again, if we have been taking all the precautions prescribed, like if I've been wearing an N95 mask and I was wearing gloves and I was using all the precautions, then ideally it should not be. But this is a very fluid situation, and what the government authorities will take a stand is anybody's, not a guess, but it's something which is to be seen. But as per my understanding, if I have been wearing a proper mask and doing all the precautionary steps, then I should not be quarantined. And there are protocols being followed in Singapore and Japan, where they say that if you've been in contact with a COVID-19 patient for less than 15 minutes, that's I think for Japan, and less than 30 minutes for Singapore, or vice versa. They have different guidelines. If you've been in contact for less than that amount of time and you were wearing a mask, and if the patient was also wearing a mask, then even more so, then you can even continue working in a hospital setting, but you continue to wear a mask, and if you turn symptomatic, then you get tested. So
okay, that's great. One should also remember that now, as you are leaving the clinic, one important point which all of us should emphasize is that the doctors should leave all the things in the clinic, like the pen, the stethoscope, and everything. And some of us, if at all we have used pulse ox for some reason or the other, you have to just see that it is sterilized, even the thermometer. And as far as possible, while entering the clinic, see that you do not have all those accessories. Particularly women should now keep away from the golden rings, the diamond rings, and the necklaces, and all those accessories are not required, because any surface is the favorite place of this virus, and surface disinfection is, aap kitna karoge, how much will you do that? So sky is the limit for that. Anyway, now Rajesh, are you able to listen to us, and are you able to any input from? I'm sorry, we are unable to listen to you. And anyway, now we have some additional time of about 10 minutes with us. So I think, Dr. Bala, now you have come home, your wife is waiting for you, your children are waiting for you, and your parents are all around. And then they immediately want to ask you as to how was the day, how you fared in the clinic, and now really you want to say so many things to them. So as you enter into the house, what all things you should remember in this current situation?
The guidelines that have been given in one of the Malad Medical Association PowerPoint are very interesting to read. One, you have to call up your house and inform the king is arriving.
Okay.
Why? Keep the door open. Ask them to keep the door open so that you don't touch the door handle. Two, like old villages, they are supposed to keep one source of water for you outside with soap and water. Wash your hands and then only enter. Three, you are supposed to leave your shoes outside, and it is recommended you better use your old worn shoes which have been lying in the corner of the house by rotation. Wash them and reuse them, and then do not touch anybody. Keep social distancing, however young you are, inside your house with your wife and others, and then enter the house. Straight away go to the bathroom, have a nice shower, and it is recommended you must shampoo your hair and lose all the hair that is still remaining in your scalp every time you take a bath. Then the clothes should be washed in hot water separately. Then if you are wearing glasses, if you are having cell phone, you are supposed to have sterilized it right in your clinic using alcohol. Put it in a plastic cover and then bring and use it. If at all you are carrying a cell phone to your clinic, then only do anything else in the house. I don't know how it is going to be possible for me once I start my practice. And in addition, you're also supposed to keep away from high-risk population inside your house, which could include the senior citizens, adults with chronic conditions, etc.
Yeah, Gaurav, you have any additional suggestions?
Yes, sir. I think these guidelines can be simplified a lot as I said, if we go to the clinic and we change our clothes, and before stepping out of the clinic, we change again. It's not that difficult. We have a washroom in every clinic. We keep a couple of clothes there. And if we don't have facility to get them washed in the clinic, we can bring them back separately and get them washed separately. And using the age-old practice of leaving our outside footwear outside the house, and just like you make everybody take off their slippers outside so that patients feel, there are a lot of patients. I remember your talk. So we can leave our footwear which we wore in the clinic. We can leave it outside, and we clean the fomites. But yes, we can't get away from taking a hot shower immediately on reaching home. But it's not possible to get the king's welcome every time. You need to manage certain things yourself.
Yeah. And as I can understand, the precautions are not only for the doctor, but they are equally for the diabetic parents, the hypertensive wife, and all those who are at the house. They have to be taken care of, and that's really very, very important. And one important thing I always tell is DTH, direct to home. From the clinic, DTH, directly go to home. Now there is no way, of course. So many people are embarrassed. The many important outlets for so many people are closed. And Acha, one quick question, Gaurav, about there are so many people even at my house. My old mother-in-law, who is staying with me now. Actually, she was going back to her own place, but now because of COVID, she has been with me. And she always says, Pramod, when you come home, do hot water gargles. You have haldi in the milk. Then you better stand in the hot sun in the daytime. So there are so many things which are there traditional, and of course we cannot just dispose them off. So have you given a thought to all this? I understand that they may not be scientific, but if someone asks you, what would be your answer? The patients might ask you, or have you given a thought? Maybe yourself or Bala, what is your opinion? Because these things are being asked.
But I think we need to be rational as well as accepting of all such views. So rationally using these guidelines would be that there's no harm and there's always benefit of having warm water. We should avoid chilled water. Obviously, there are certain things which can't be taken hot, and we do make exceptions for that especially in the late evenings. But during the day, I think we prefer to have warm water, and it's always good for throat hygiene, as it is called. So I think out of all of these, sipping of hot water after a meal or before going to bed is something which is recommended by our system of medicine as well. But for the others, I would usually tell my patients that if you want to use something, if it's not harmful, kind of, they're not doing very extensive Ayurvedic or something, but just to take some haldi or honey and tulsi and all, we don't discourage them from doing it.
Okay. And Bala, now we are almost coming to the end of our discussion of the
Sir,
day.
I think Dr. Rajesh would have his audio back by now.
Rajesh, your audio, has it started working?
Am I audible?
Yes.
Wonderful. I just...
Am I audible now?
Yeah.
Yes.
Very good. If whatever we have discussed up till now, if you have any...
Yeah, I am with you. I just wanted to add that when you are talking about, the patient blaming you for having given the corona, etc. So it just reinforces the point that we need to document everything very well when we are seeing the child. And as Gaurav has been saying, if we digitalize, that documentation becomes easier, because it doesn't take so much time. At the click of a button, the same sentences can be easily put on paper, etc. So I think that's another everyone will have to get used to digitalization to help documentation.
Yeah, that's great. Okay, we are now coming to the end of our discussion, and Bala, there are some important points which we would like to listen from you. And last so many days now, we are not seeing the patients. We are also isolated, and people call it as social isolation. And the income on one side is going down. Some people are worried about that also. So in case if people become anxious, or some of us go into depression, one should not be worried about, or others should not be surprised. So how would you look at it? In a brief, just tell me as to how our colleagues should look at it at this particular moment, and then I will just conclude with my concluding remarks. So just give us some of your thoughts on this.
One, pediatricians should never get depressed. We are like children. We should always be happy individuals, like the children we treat. Two, in pediatrics, if you look at chronic diseases, the prognosis is much better in pediatrics when compared to geriatrics. So similarly, this depression of decline in practice, unpaid holidays, layoffs should not defeat us. Like children who bounce back from serious illness to normalcy, we pediatricians should look at the whole scenario positively and reassure ourselves that we will bounce back to normalcy. 3, whatever time that we have, we should think of it as a God-sent opportunity to do things which you otherwise want to do and you have not been able to do. But of course, you should not include things like drinking. Quality time should be spent with the family. Quality time can be used for academics, learning music, learning French, learning computer, learning new things in religion. There are so many avenues available for relaxation. And you must also think that this is the best God-sent opportunity for you to improve your physical fitness, use your home gym, lose some weight, enter into a new scheme of dietary discipline, yoga, meditation, pray for the whole world so that the world and the children we treat and the pediatric fraternity bounce back to normal faster than ever before.
Oh, that's wonderful. I will now conclude by, just telling you that I 100% agree with you. The symbol of our profession has been plus, and then we have to be positive. And it is said that the positive frame of mind also gives psychological immunity. And I would not leave our listeners without listening to a mnemonic, which is included in my own name of Pramod. So P stands for patience. Be patient. The days will be over. R stands for resilience. You have to come back from where you are. A stands for acquiring new skills. As you said rightly, having some new hobbies, as I have started learning French. M stands for making others positive. Don't make others negative. So make others positive. O stands for observing discipline, which we have discussed all throughout these 1.5 hours. And D stands for do not hesitate to call me on my mobile in case of depression. Okay. And that's Pramod. And I feel everybody has got so many points from the discussion with the galaxy of the panelists. When I say galaxy, it includes me also. And that's why, I thank the Sipla Facebook Live for giving us an opportunity to interact with you. And I thank all the listeners, viewers for giving a patient listening. Of course, we are not able to see their reaction, but then before they show any reaction, we will close down. Anyway, so bye and good night. Have happy home, stay safe. That is what everybody is saying. Okay, bye.
Right, sir. Right.
So just wait for a minute.
Yeah, we are here.